Hi everyone, this is Professor Butts. I'm going to give you a recorded lecture for the case study slide for nutrition, and then I'm going to complete the bowel elimination lecture. Okay, so here's the case study. For the first question, in this case study, in assessing your patient's nutritional status, what data should be included? That should be the usual dietary intake, their food allergies or intolerance, food preparation and storage, type of dietary practices, eating disorder patterns, medications, history of drug dependence or abuse, their ability to chew and swallow, state of their dental health, bowel habits, age, sex assigned at birth, family history, social determinants of health, exercise and sleep patterns, knowledge of nutrition, access to reliable health and healthy foods, use of alcohol and tobacco, religious affiliation, cultural and ethnic backgrounds, anthropometric data, body mass index and weight circumference is included in that, clinical data, and biochemical data. So those are your lab tests that we discussed. Second question, outline potential clinical barriers to dietary intake. Potential clinical barriers could be dysphagia, which is difficulty swallowing, aspiration, diminished sensory abilities, dental problems, weakness, or fatigue. The lab tests that provide useful data regarding nutritional status, these were the ones we discussed. Hemoglobin hematocrit, because of O2 carrying capacity and iron levels. Prealbumin shows dietary status and whether malnourished. Transferrin is an iron transporting protein. Blood, urea, nitrogen is breakdown of amino acids. Serum creatinine, and these tell you about your body's muscle mass. So low levels indicate malnutrition. Blood glucose, cholesterol, and triglyceride levels, in a 24-hour urine. What psychosocial or sociocultural factors can influence nutrition? So those included language barriers, knowledge of nutrition or literacy, lack of caregiver or social support, social isolation, limited access to food, lack of or inadequate cooking or food prep arrangements, religion, meaning of food, and culture. Okay, so now we're going to move into the bowel elimination. So this is the anatomy and physiology. You're going to be looking at the stomach, where your food stored, secretes digestive fluids, churns food to aid in digestion. Small intestines. Um, this is where enzymes are secreted that digest proteins and carbohydrates, digestion of food and absorption into the bloodstream. And then your large intestine is primary organ of bowel elimination. Large intestines, just a little bit more about that. Primary organ of bowel elimination, as we said, extends from the ileocecal valve to the anus, and again functions absorption of water, formation of feces, and expulsion of feces from the body. Your small and your large intestines are depicted in this picture. Process of peristalsis. So peristalsis is under control of the nervous system, and there could be 3 to 12 minutes. You should contractions occur. Mass peristalsis sweeping occurring 1 to 4 times each 24-hour period, and 1/3 to 1/2 of your food waste is excreted in stool within 24 hours. So variables influence your bowel elimination. There are many factors that influence. Again, starting off with developmental considerations. In infants, they have no involuntary control. Their stool varies by the feeding type. Toddlers, bowel control develops around 18 to 30 months. From children to adults, patterns vary, and we usually need to educate on healthy habits. Older adults, you have slower peristalsis, but constipation is not a normal part of aging. Often it's due to medications or lifestyle and may require an intervention. Daily patterns. Most people have a routine, time, and place for their bowel movements. Ignoring the urge can lead to constipation. Privacy and positioning are an important part of effective elimination. High fiber diet and adequate fluid intake. At least around 2,000 to 2,600 milliliters a day promote regularity. Food intolerances could affect bowel elimination, such as like lactose. It can cause diarrhea or gas. Activity and muscle tone. Exercise stimulates peristalsis. Inactivity, especially bed rest patients, they have increased constipation risk. Cultural habits, stress, emotional states can affect your bowel function, such as anxiety may cause diarrhea, chronic stress may lead to constipation. Diseases like irritable bowel syndrome or colon cancer, cystic fibrosis, diverticulitis can cause an alteration in bowel habits. Narrow stools may indicate obstruction. Foul-smelling, greasy stools may suggest malabsorption problems. Medications such as laxatives promote peristalsis. Antidiarrheals will slow it down. Opioids and antacids can cause constipation. Antibiotics may cause diarrhea or lead to C. difficile infection, which is a serious healthcare associated infection. Diagnostic tests and surgery can factor into bowel elimination. So like bowel preps or and fasting can disrupt your normal patterns. And then surgery and anesthesia may cause temporary ileus, which is a stoppage of peristalsis. And we monitor for when peristalsis starts again after surgery and anesthesia before adding food. And here's a few more foods, information about foods that affect bowel elimination, such as constipating foods, cheese, lean meats, eggs, and pasta may cause constipation. Foods with a laxative effect, fruits and vegetables, bran, chocolate, alcohol, coffee. Some gas-producing foods include onions, cabbage, beans, cauliflower. Remember, nursing histories, when you ask questions to gather information about bowel elimination, we're going to be asking questions to help us identify their normal patterns, problems, and guide care planning. So usual patterns of elimination, you might ask, how often do you move your bowels? Is there a usual time of day? What does your stool typically look like? We're going to be assessing for frequency, timing, stool characteristics, such as amount, consistency, shape, color, odor. Straining or manual removal of stool. Aids to elimination. We'll ask, do you use anything to help move your bowels? We'll explore natural aids like fluids, foods, medications, such as laxative use, enema use. We'll ask about any recent changes in their stool, color or presence of blood, the shape or appearance, if any of that has changed. This will help us detect early signs of GI issues or bleeding. We'll ask about any current problems with their bowels. We'll assess for nature, onset, and frequency of symptoms. Contributing factors such as diet, mobility, medication, or stress, severity, and any attempted interventions they've tried at home. We'll ask about whether or not if they have a bowel diversion, what their routine with their colostomy or ileostomy. Do they have any problems caring for it, and how has having this diversion affected their daily activities? Okay, for physical assessment of the GI system, we focus on the abdomen, anus, and the rectum areas. That'll help us identify constipation, diarrhea, or bowel obstructions. For the abdominal assessment, we'll follow this sequence. We'll do inspection first, always, and then auscultation, and then percussion and palpation. This prevents percussion and palpation altering any natural bowel sounds that you would hear through auscultation. Positioning, we place the patient in a supine position with their knees slightly flexed. Ensure their abdomen is exposed, and we make sure that we ask about whether their bladder is empty, because we want to empty their bladder before we proceed. For inspection, you'll look for contour, symmetry, scars, masses, or distension. We'll note any swelling or protrusions. We'll auscultate with a warm stethoscope, listening for bowel sounds in a clockwise pattern. Normal is anywhere from 5 to 34 sounds per minute. Hypoactive would be less than 5 in a minute. That may happen like after surgery or if there's peritonitis. Hyperactivity can happen with diarrhea or gastroenteritis, and that's above 34 a minute. Absence, we listen for 2 minutes before confirming. If the patient has an NG tube, we disconnect it because that will may interfere with hearing the whether or not those are actual bowel sounds or not. We also disconnect it from suction. That we disconnect the NG tube from suction before we do the auscultation. For palpation, we're going to use light palpation in all quads. 4 quadrants of the abdomen, we're going to watch for pain or tenderness, and if there is a painful area, we're going to palpate that last. We're going to be noting firmness, masses, or resistance. Generally, percussion is performed by advanced practitioners. For the assessment of the anus rectum area, we're going to perform a superficial inspection during any time we're doing hygiene or bowel care, looking for lesions, ulcers, fissures, external hemorrhoids, skin irritation or breakdown. If you ask the patient to bear down, which is the Valsalva maneuver, you can check for internal hemorrhoids or fissures. Advanced rectal exams are typically done by providers with specialized training. Proper procedures for stool collection include safety, patient education, and the types of stool tests. So general procedure, we have nurses must follow facility guidelines for collecting, labeling, and transporting stool specimens. You want to make sure you use the correct container and gather the correct amount of stool. You're going to always wear gloves, disposable gloves, and perform hand hygiene before and after, avoiding contaminating the outside of the container and ensuring it's sealed properly. Patient instructions, you're going to use clear, familiar language. Some patients may not understand the word stool. You're going to give key instructions is to ask them to void first to avoid urine contamination. They're going to defecate into a clean container, not in the toilet. They're going to avoid putting toilet paper in the sample, keeping stool away from soaps or disinfectants, and you're going to notify the nurse when the sample is ready so it can be transported. Handling, you're asking if the patient is, let me clarify, if the patient is collecting the sample on their own, you want to let them know to notify you immediately so that you can gather that sample and transport it to the lab quickly, timely. Handling of the specimen, you want to use gloves, tongue blades to transfer stool, collect 1 inch, 2.5 centimeters of form stool or 30 milliliters of liquid stool. You're looking for any visible blood, mucus, or pus. You want to avoid samples that when a patient's had a barium or enema solution, you don't want any sample with that. Again, send it immediately to the lab or follow storage instructions. You do not refrigerate specimens for ovum parasites. Typical types of stool tests, they do stool cultures looking for bacteria, virus, fungi, or parasites. We collect those before starting any antibiotics. Occult blood testing detects hidden blood in the stool. They're used for screening for ulcers, bowel disorders, and colon cancer. Black stools may indicate an upper GI bleed. Red blood may suggest lower GI bleeding. There's different types of tests for occult blood. Fecal occult blood test is used to detect blood in the stool, but they also do a guaiac fecal occult blood test, and that detects blood with a chemical reaction, and it may be affected by medications in certain foods. There's also a fecal immunochemical test, or FIT. This uses antibodies to detect human blood, and there's no drug or dietary restrictions for that test. Patient prep tips for occult blood tests is to avoid buried enemas for 72 hours. Don't collect during menstruation or if you have hemorrhoids. Note any conditions that may affect the results. So if any of that's going on, you want to be able to indicate that. Start time the time specimen, so you want to start timing when the first stool is passed. You collect all or part of every stool during the time period, and you're going to follow live instructions carefully at the facility. Stool characteristics, what you're going to be observing for is when assessing stool is pay attention to frequency, how often the patient has bowel movements. The amount, is it typical or unusually large or small? You're going to note the appearance, which includes volume. Um, Normal volume varies depending on the diet. You're looking to consider, your considerations would be like high fiber diets produce more stool. Large watery stools may suggest small bowel issues. Small frequent stools may point to a problem in the colon or the rectum area. You're going to look at color. Normal for infants would be yellow to brown. Adults, it's brown due to bowel pigment. You're going to consider if you find black stool, that may indicate bleeding in the upper GI, as we said before. Red blue may be lower GI or hemorrhoids. We said that earlier. If it's white or clay color, that may signal absence of bowel. Diet and medications can also affect the color, like iron or bismuth. That's like in Pepto-Bismol. That can cause black stools. Antacids, whitish stools. Red meat or spinach may uh, affect the stool and make it darker. Odors, normal is a pungent, affected by diet. You consider things like if it has putrefaction or fermentation or strong odor may indicate excessive bacterial activity in the blood or stool. Consistency, normal would be soft, semi-solid in form. If it can be influenced by fluid intake and how long stools stay in the intestine. So if it's faster transported through the intestines, you're going to have looser stool. If it's a slower transit, you're going to have harder stool. The shape, it's normal, it's tubular, about 1 inch in diameter. Narrow or pencil-shaped stools may suggest an obstruction. If it's hard or marble-like, that may result from being prolonged time in the colon. Constituents, it includes bile, bacteria, shed cells, and undigested food. That's normal. Abnormal findings would be blood, pus, excessive fat, parasites, or ova, mucus, and foreign bodies.
Endoscopy is the direct visual examination of body organs or cavities. And this is usually done using a fiber optic endoscope, which is a long flexible tube with glass fibers that transmit light into the organ, and then it returns an image that can be viewed. So these are some examples of direct visualization diagnostic exams that allow direct viewing of the GI tract using the scope or imaging tools. So an EGD, or esophagogastroduodenoscopy, examines the esophagus, stomach, and the duodenum. Preparation, the patient will need to sign a consent. They're fasting for 6 to 8 hours, so nothing by mouth. 6 to 8 hours beforehand. They'll have to remove dentures. They are administered sedation, and they'll have their throat sprayed to reduce the gag reflex. Aftercare, nursing responsibilities, will withhold food until the gag reflex returns. Monitor vital signs. We'll be watching for signs of perforation. pain, vomiting, blood, and black stools. Throat soreness is normal after having this type of procedure. The second endoscopy is a colonoscopy. That's going to be using the scope to examine the rectum, colon, and the distal small bowel. Preparation again is a sign of consent. They'll have a low residue diet followed by clear liquids. They'll do a bowel prep. It could be a split dose or an enema. Nothing by mouth for 6 to 8 hours before the procedure. And aftercare is we educate that they should expect gas or bloating. They'll be able to resume normal diet after sedation wears off. We'll be monitoring for rectal bleeding or abdominal pain. Sigmoidoscopy is examination of the sigmoid colon, rectum, and the anal canal. Preparation, again, is assigned consent. They'll be permitted a light meal, and there'll be enemas or an oral prep for older adults. Sedation is usually not required for this procedure. Aftercare, again, educating about gas or bloating may occur and monitoring for bleeding if a biopsy has been done. The capsule endoscopy is virtual enteroscopy. The patient will swallow, like I had mentioned before in class, they swallow a camera capsule that takes thousands of images of the small intestine. Preparation is there'll be NPO for 10 to 12 hours. There's no eating for 2 hours after ingestion. Light meals are allowed after 4 hours. Avoid vigorous activity and an MRI until capsule is excreted. Advantages, there's no sedation or discomfort. Normal daily activities are possible. Limitations is you cannot take biopsies. May require follow-up procedures. Um, and that is about it for those. Um, it is excreted through defecation. Visualization diagnostic exams, these include imaging techniques like x-rays or CT scans, ultrasounds that will allow you to visualize the GI tract. The first one listed is the upper GI and small bowel series. Patients will drink barium sulfate to coat the GI tract. They're NPO after midnight. They sign a consent. They're informed about the barium, which is has a chalky taste. Aftercare is laxatives to help pass that barium because it will cause severe constipation or could lead to an obstruction. We're going to be monitoring for stool color. Um, the barium enema, barium is instilled into the colon via a rectal tube. We have to have a consent. There's a bowel prep to clear the colon of feces. We're going to be checking for contraindications of using the barium. Aftercare would be encouraging fluids, rest, and monitored stool color. We also could do an abdominal ultrasound, which uses sound waves to visualize the organs. The prep is NPO for 8 hours. There's a gel that's used just like with other ultrasounds. Schedule before any barium studies because barium will not allow for visualization through the ultrasound if it's done prior to an ultrasound. Aftercare is just removing of that gel and resume normal diet. An MRI, that's the magnetic resonance imaging. It uses magnets and radio waves for detailed images. The prep is screening for metal implants, getting a consent. There may be possible sedation. We talked a little bit about that. Sometimes people have some claustrophobia with MRI, CT scans with the equipment. We talked a little bit about CT scans and our x-rays such as the KUB, kidney, urethra, and a bladder x-ray and how this area of the abdomen you can see, for instance, if the colon has an obstruction or fecal matter. That's going to be important to remember for test. The PrEP is an oral or IV contrast, checking for allergies to any contrast, and kidney function because it's contraindicated for use of that contrast if there is kidney issues, and nothing by mouth after midnight. Aftercare would be monitoring for contrast reactions and sedation effects. This slide is just showing some of the outcomes for normal bowel elimination or goals if you're setting up a nursing care plan for someone with bowel elimination issues. So the outcomes that we would like to see for normal bowel elimination would be soft form bowel movement without discomfort, able to explain the relationship between bowel elimination and dietary fiber, fluid intake, and exercise, able to relate the importance of seeking medical evaluation if there are changes in their stool color or consistency that are persistent, and skin integrity is maintained. Maintaining regular bowel habits is essential for both well and ill patients. We can support our patients as nurses by focusing on 5 key areas, and that's timing, positioning, privacy, nutrition, and exercise. Timing, we want to encourage patients to use toilet at their usual time, especially about an hour after meals when that's a natural time for bowel movement urges to occur. Ask patients what works best for them and offer assistance to get to the toilet, commode, or bedpan. Educate the patient not to ignore the urge to defecate because delaying can lead to constipation. Positioning, sitting upright on a toilet or commode helps with defecation. Using elevated toilet seats for patients with orthopedic issues. Uh, a small footstool can help raise the knees above the hips and improve stool passage. That's what the squatty potty is. It's actually the stool that helps you get your knees in that position. Avoiding bedpans when possible, and if necessary, elevate the head of the bed to at least 30 degrees. Providing hand wipes for hygiene after toileting, privacy. Many patients cannot defecate in the presence of others, so providing privacy by pulling curtains, asking visitors to step out, leaving the bathroom if it's safe to do so. For patients uncomfortable in public restaurants, suggest using a single toilet restroom. Hygiene, again, we said if they're using bedpans or commodes, then they may struggle with personal hygiene. So assisting them with that by providing like warm, moistened, disposable washcloths or gentle cleansers for comfort and skin protection. And always offer hand hygiene after toileting, prevent infection. Nutrition, you want to encourage for them to have high fibers and encourage in that at least 2,000 to 3,000. We said a good intake is about 2,600 milliliters per day. That's the average that's recommended. Be cautious with fluid intake if the patient has cardiac or renal issues. However, that can be too much fluid for them. Remind patients that fiber without enough fluid can worsen constipation. Exercise will help with improved GI motility. Encourage patients to walk or move as soon as they're able. For immobile patients, you want to suggest bedside exercises or pelvic floor muscle training, Kegels that we talked about earlier. It also strengthens rectal muscles. Constipation is a common but often overlooked issue that affects comfort, health, and quality of life. Constipation is defined as dry, hard stool, infrequent or difficult passage of stool, feeling of incomplete evacuation. If someone has, even if someone has a bowel movement daily, they may still be constipated. On the other hand, some people who go only a few times a week may not be constipated. What causes constipation? The main cause is decreased gastric motility when the movement of food through the intestine slows down. This can lead to more fluid being absorbed from the stool. It becomes dry and hard, and straining during bowel movements may occur. So, who's at risk? People that are at Higher risk include patients on bed rest or limited mobility, those that take medications that may cause constipation, like opioids, anticholinergics, people with low fluid or fiber intake or at risk. Also, people who are depressed or have neurological conditions or painful lesions in the rectal area can also be at increased risk for constipation. Right. Next up is diarrhea. So, what is it, why it happens, and how can nurses care for patients experience it? Diarrhea is an increase in stool frequency, usually 3 or more times a day. There's a change in the consistency of the stools, looser or watery stools. It's often accompanied by intestinal cramps, nausea, vomiting. Sometimes there's blood in the stool. Why does diarrhea occur? It can be a protective response. It's the body's way of flushing out the irritants in the intestinal tract. But it also can lead to this can lead to rapid loss of fluids and electrolyte imbalances, especially in infants, young children, and older adults. If untreated, diarrhea can cause serious complications like dehydration, vascular collapse, hypovolemic shock, electrolyte imbalances like low potassium or magnesium. It can lead to metabolic acidosis. So nursing care for diarrhea is one, we want to identify the cause. Acute diarrhea may be due to an infection, medication, diet changes. Chronic diarrhea that lasts more than 2 to 4 weeks may be caused by inflammatory bowel disease, irritable bowel syndrome, malabsorption, tumors, or side effects from medications or laxative abuse. You want to replace fluids. We use oral fluids if they can tolerate them or IV fluids if needed. And we monitor for signs of dehydration. We want to avoid antidiarrheal medications unless we are sure that there's not a bacterial cause. We want to make sure that we treat the bacteria. We want to support the patient, respond quickly to call bells, keep a bedpan or commode nearby, help maintain their dignity and comfort. Also may need to protect their skin, clean around the anal area gently to prevent irritation and use barrier creams if needed. Food poisoning can lead to serious gastrointestinal symptoms, especially diarrhea. So we're going to look at how it affects the body and what nurses can do to help. So what's happening during food poisoning? Foodborne infections like those caused by E. coli can cause severe abdominal cramping, watery or bloody diarrhea, nausea, and vomiting. They're infections and they can be especially dangerous for young children under age 10 or older adults. In severe cases, complications may include kidney failure, blood disorders, life-threatening dehydration. To diagnose and monitor, we will take a stool sample to confirm any infection. The nurse is going to be monitoring fluid and electrolyte levels, signs of worsening symptoms. We'll monitor vital signs and their urine output. The nursing care party hinges on a lot of it is on supportive treatment, encouraging fluid intake or administering IV fluids if needed. Again, we avoid antidiarrheal medications until we have ruled out an infection. We provide skin care to prevent irritation around the anal area and barrier cream. Patient safety is also an area that we want to prioritize, responding quickly to call bells, keeping bedpan and commodes nearby to prevent falls. The education we're going to provide is teaching patients and families about hygiene, hand hygiene, and reporting symptoms early. A bit more about preventing food poisoning. We want to use food thermometers to ensure cooking food to a safe internal temperatures. You want to keep food hot after cooking, maintain safe temperature of 140 degrees or above. And you only want to give pasteurized fruit juices to small children. There are several methods used to help promote elimination of feces. That's enemas, rectal suppositories, oral intestinal lavage, and digital removal of stool. And you can read about more about each of these in your text, but here and the text provides kind of short descriptions. I'm going to discuss the enemas on the next slide. Enemas are commonly used to relieve constipation, prepare patients for surgery or diagnostic exams, and to administer medications. So we're going to look at a couple of different types and their purposes and how to safely administer them. Cleansing enemas. They're given to relieve constipation or fecal impaction. They empty the bowel before surgery or prepare one for a radiographic or endoscopic exam. The types of cleansing enemas, you have your hypotonic, which is tap water, and isotonic, um, which is normal saline solutions. And, and these enemas are large volume enemas that result in rapid um, colon emptying. However, using such large volumes of solution for adults is 500 to 1,000 milliliters, and infants it's less than 250 milliliters. Can be dangerous for patients with weakened intestinal walls, such as those with bowel inflammation or some type of bowel infection. Hypertonic solutions, phosphate and sodium citrate, are enemas that are available like in stores commercially. They're administered in smaller volumes. Adults, it's usually 118 to 197 milliliters. These solutions draw water into the colon, which then stimulates the defecation reflex. They can be contraindicated in patients with sodium and or water retention. That is a problem for them. So renal patients are maybe contraindicated in. Retention enemas, these are solutions are held in the bowel longer for specific effects. Oil retention, it lubricates the stool and mucosa. Carminative enemas, they relieve gas, and examples of those would be milk and molasses enema, or there could be medicated enemas that are used to deliver drugs via the rectal mucosa for absorption. We use clean technique. We always wear gloves. Um, you're going to use, for large volume enemas, there'll be tubing and clamp and container and solution. For hypertonic enemas, those are the prepackaged kits and they come with lubricated tips. We always want to protect the patient's privacy and explain the procedure clearly. The patient preparation, you're going to position them in a left side lying with their knees flexed. We avoid Fowler's position. It prevents proper flow. We encourage the patient to retain the solution for the best results and provide reassurance and maintain their dignity. Some special considerations for hypertonic enemas. You want to use caution with if the patient has hemorrhoids or fragile rectal tissue. Oil retention enemas, you want to administer those at body temperature and have them retain them for about 30 minutes. Post enema care is monitoring for effectiveness, clean the area, and document results. You might want to do a little bit more studying from your textbook on the enemas and note the time frames to on the previous slide, time frames to retain the enema solutions. So we're going to look at managing bowel incontinence. Bowel incontinence or fecal incontinence is a loss of voluntary control over defecation. It can be distressing for patients and challenging for caregivers. We're going to look at causes, nursing interventions, um, and management of any devices. Incontinence is not life-threatening, but it can be embarrassing, depressing, damaging to skin integrity. We need nurses to be ones who provide compassionate care and support dignity. Some nursing interventions to manage bowel incontinence includes identifying patterns and assist with toileting at expected times. If you can identify a pattern, then offer toileting every few hours. You want to keep the skin clean and dry and apply protective barriers. You're going to change the linens and clothing as needed. You're going to use disposable pads or moisture-proof garments only after other options have failed. Because if you use pads or these moisture-proof garments like the pins or adult diapers, it can cause worsen skin irritation, which is called incontinence-associated dermatitis. And this occurs when you have prolonged contact with stool or urine, and it will appear red, inflamed, and the skin will break down. And you'll have pain and burning and itching. There's increased risk of pressure injuries and infections as well. Some skincare tips would be to clean the skin daily after each episode. We want to use pH balance, no rinse cleansers, avoiding soap and scrubbing and friction, employing moisturizers and skin barriers, and use any type of product that would wick away moisture. You may also want to get a consult with a wound care specialist if they do end up with some kind of breakdown that doesn't improve within 2 weeks. Management of devices. Sometimes they have an indwelling rectal tube. These are used for patients with uncontrollable diarrhea. It'll direct stool into a collection bag. The risk include leakage, skin damage, or injury to the rectal sphincter. You want to use with caution and monitor very closely. Another option would be an external anal pouch. We want to protect the skin from frequent loose stools. It adheres around the anus and connects to a drainage bag. You want to apply before their skin damage occurs. If there's already skin irritation, you're going to need to use a barrier cream first. Monitoring for leakage or skin damage from adhesives as well. We talked a little bit about scheduled toileting. This is a little referred to as a bowel training programs, and they're designed to help patients regain control over their bowel movements. These programs are especially helpful for patients with chronic constipation, fecal impaction, or bowel incontinence. The purpose is to help the patient establish a regular pattern of defecation, to pass soft form stools without using laxatives, improve muscle tone and bowel awareness, and this can be done in the healthcare setting or at home. Some key components of the program is planning. We involve the patient and the caregiver in all the planning. We choose a regular time for bowel movements, ideally 20 to 40 minutes after meals when you have natural bowel activity increasing. Monitoring by tracking bowel movements for frequency, consistency, shape, volume, color. Stimulation techniques might include using suppositories or small enemas if needed. Drinking warm prune juice or fruit nectar may help. Teaching digital stimulation by inserting a lubricated glove finger into the anus, making circular motion until the sphincter relaxes, and this encouraging abdominal muscle contraction and bearing down. Repeating this daily until a pattern is established. Some supportive measures, again, privacy, ensuring the patient has privacy during toileting to reduce anxiety, promoting success. Fluid intake, again, we encourage between 2 to 3,000 milliliters of fluid per day. We told you that magic number was about 2,600 unless it's contraindicated. Nutrition, you want to teach patients about high fiber foods because that promotes regularity. Exercise, like recommending Kegel exercises to strengthen pelvic and rectal muscles is all part of a bowel training program, and it requires a lot of patience and support of the client. We're going to talk a little bit about nasogastric tubes or an NG tube. It's a flexible plastic tube inserted through the nose into the stomach. There may be a single lumen for feeding or medication, or there could be a double lumen, one for suction and airflow. The NG tubes allow for removal of stomach contents like fluids, air, or toxins. Um, it's used for installation of medications or nutrition. They're commonly used to decompress the stomach in case of like a paralytic ileus is when you have absence of bowel sounds and peristalsis is not happening, or there's an internal obstruction. You can use it to drain unwanted contents such as poison or excess fluid. They use NG tubes to rest the GI tract before or after surgery. You want to note that routine use of NG tubes after surgery is no longer recommended, but research shows that it may actually delay recovery and increase complications, but you may still run into some that providers who use them. So how does an NG tube work? It's inserted through the nasopharynx into the stomach. It's connected to suction, either continuous or intermittent. For double lumen tubes, one lumen suctions stomach contents, and the second allows for airflow to prevent any damage to the mucosa. We may include, there may be included a one-way anti-reflux valve to prevent backflow. Some nursing responsibilities include insertion and removal. You'll be learning how to do this later in the program, not this semester, but there is some directions on how the skill is performed in your textbook. We do irrigate the tube using 30 to 60 milliliters of normal saline every 4 to 8 hours to keep the tube clear. We monitor for complications, nasal irritation. We talked about that already. Blockage, discomfort. We document output and patient responses. NG tubes are a vital tool in managing GI conditions, and we play a key role in ensuring its proper placement, maintenance, and patient comfort. So, a little bit about ostomy. So, what's an ostomy? It's a surgically created opening in an organ. In GI procedures, the intestinal mucosa is brought to the surface of the abdomen and sutured to the skin, forming a stoma. The stoma is a visible part of the ostomy where stool exits the body. There's different types. There's the ileostomy, which is created from the ileum, which is a part of the small intestine. It eliminates liquid fecal content. A colostomy is created from the colon. It eliminates foreign feces. It's classified by its location: ascending, transverse, descending, sigmoid. And I'm going to have some diagrams on the next slides. An ostomy can be temporary or permanent. Temporary ostomies allow healing after surgery or an injury. Permanent ostomies are used for chronic disease or cancer and remain for life. If surgery is planned, patients often meet with a wound ostomy incontinence nurse. This nurse helps them choose the best location for the stoma. Proper site marking reduces complication and improves outcomes. Restorative procedures with a J pouch. IPAA, it stands for ileopouch anal anastomosis. It's used for patients who have ulcerative colitis or hereditary colorectal cancer. In this procedure, the colon and the rectum are removed, but the anal sphincter is preserved, and a pouch is created from the small intestine and connected to the anus. Patients can control their bowel movements naturally. A temporary ileostomy may be placed to allow for healing of this. And there's a figure 3911 that you can look at to see what a J pouch looks like. So on this diagram, A is a sigmoid colostomy and B is a descending colostomy. Here on picture C, you see a transverse colostomy, and on D is an ascending colostomy. And here you can see the location of an ileostomy. Caring for a patient with a colostomy involves more than just physical care. It requires emotional support, education, and encouragement. The physical and psychological support should begin before surgery and continues after surgery. Patients benefit from care provided by a woundostomy continence nurse because they're specialists. We want to encourage involvement of family, caregivers, and support groups. Um, Stoma assessment and care is another part of colostomy care. We're going to inspect the stoma regularly. The stoma should be dark pink to red, moist, and protrude about 1 to 3 centimeters above the skin. A pelstoma, which I have a picture on another slide to show you, may indicate anemia. A dark or purple blue stoma may signal poor circulation or ischemia. You're going to watch for mucocutaneous separation. That's when the stoma pulls away from the skin, and you want to make sure you notify the healthcare team if there is bleeding, excessive bleeding, color changes occurring, or if the stoma appears to be separating. You're also going to look at the peristomal skincare, which is the skin around the stoma, keeping it clean and dry, looking for signs of irritation, infection, or yeast infections, candida, properly to improve uh, care of this area using a properly fitted appliance, preventing moisture associated skin damage is the goal. Avoid redness or discoloration, especially patients with darker skin tones, maybe a little bit darker, a little bit more difficult to see. So make sure you're doing a proper assessment. Managing output, you're going to monitor fluid intake and output. Check the quality and quantity of the discharge from the ostomies. As peristalsis returns, you're going to notice that stool will begin to pass through the stoma. You're going to provide education and promote patient involvement. So teach the patients and caregivers about appliance care, skin protection, odor control. Make sure you encourage patients to look at their stoma and participate in the ostomy care. Support their emotional adjustment, listen, explain, and be present. You want to connect patients with local ostomy support groups. Another area that we want to provide education and care is for odor control. You want to teach and also empty the appliance before it's half full. It's recommended probiotics like yogurt to help with odor control. There's odor eliminators like chlorophyll or bismuth, but advise consulting with a provider first before introducing any of those. The woundostomy continence nurse can also help select appropriate odor control products. After healing, patients can return to work, swimming, and sexual activity, but they should avoid heavy lifting for 2 to 3 weeks post-op. Contact sports should be avoided. You want to discuss stoma protection devices for physical activities, and when they're traveling, to carry extra supplies in a carry-on bag. First picture, you see a dark pink to red stoma that is moist. That's a normal appearing stoma. The middle picture is of a pale stoma that may indicate anemia, and the oblong looking stoma is one that has eroded skin around the area and may lead to a flush stoma where it does not protrude above the skin. We talked a little about some education, and here's a few more areas for education teaching about colostomies. You want to explain the reason that they had the bowel diversion and the rationale for treatment. You want to demonstrate self-care behaviors that effectively manage their ostomy. You want to describe follow-up care and existing support resources. report where they can get supplies, how they can get them in their community, and encourage them to verbalize related fears and concerns and demonstrate a positive body image. Key dietary considerations for patients with colostomy is odor control through diet. Again, probiotics such as yogurt can aid in digestion and help reduce odor. Chlorophyll containing supplements may help control odor, but can also turn stool green and may interfere with medication absorption. Should only be used if the healthcare provider approves them. Bismuth subsalicylate may also reduce odor, but can also turn the stool black, may interfere with medication absorption, and should also only be used if is with the provider guidance. Some general tips, patients should be educated on foods that cause gas, odor, or loose stools and how to manage these effects. You want to encourage hydration and balanced diet to support healing and regular bowel function. Dietary adjustments may be needed based on the individual's tolerance and stool consistency. Dietary considerations for patients with an ileostomy or colostomy, and foods that may cause gas or produce odor include apples, asparagus, beer, cucumbers, dairy products, dried peas, beans, and lentils, eggs, fatty foods, fish, garlic, melons, nuts, onions, pickles, radish, vegetables from the cabbage family. Carbohydrates, raffinose in these foods is poorly digested, and it's what leads to gas. This includes foods such as broccoli, Brussels sprouts, cabbage, cauliflower, and turnips. Foods that may cause stomal blockage, bean sprouts, cabbage, celery, coconut, corn, dried fruit, mushrooms, nuts, peas, pineapple, popcorn, seeds, skin from fruits and vegetables. Some foods that may help to thicken the stool: applesauce, bananas, cheese, creamy peanut butter, pasta, potatoes, rice, tapioca, yogurt. Some foods that may decrease odor: buttermilk, kefir, parsley, yogurt.